We are about to embark on a journey back in time to relive a disaster. We are going back to 2019, to the heart of COVID pandemic. Masks on, everyone.
On a seemingly ordinary day in Wuhan on 17 November 2019, little did anyone know that a calamity was brewing beneath the surface. It all started with the first reported case of COVID-19, a virus that was soon unleashed onto the world. As days passed, the world was in horror as the WHO was forced to declare it a global pandemic.
Busy city roads turned to eerie silence, shared hopes and shutting down eyes. Save Me became the desperately echoing worldwide, but as we pass out to the relentless efforts of the nation, the worst pandemic of our generation eventually reached its conclusion.
Humanity has simply tried over the disaster, or so it seemed. While many resumed their normal lives, a few faced a harsh reality. The aftermath of this battle was far from simple.
Many of us have likely come across news articles narrating perplexing tales of individuals succumbing to mysterious illnesses. Their lives abruptly cut short due to circumstances shrouded in uncertainty. Yet, what threads these disparate narratives together? What commonality exists among these unfortunate souls? Astonishingly, the unifying factor lies in their shared history of battling with COVID-19 infection. It is this very conundrum that piques our curiosity and motivates our rigorous investigation.
Before diving deep into our topic, let me put the spotlight on a very intriguing topic, long COVID. The WHO defines long COVID as the continuation or development of new symptoms 3 months after the initial SARS-CoV-2 infection, with the symptoms lasting for at least 2 months with no other explanation.
In the wake of COVID-19 pandemic, a wide range of post-COVID symptoms emerged affecting various systems. Yet, it was the cardiovascular system that bore the brunt of this storm. There was a substantial rise in cardiovascular disease-related death on a global scale. A stark reality we cannot ignore. But did the topic thought had faded into history leave an indefensible mark on our hearts?
Through our research, we intend to establish the percentage of individuals suffering from cardiovascular symptoms post-COVID and to ascertain risk factors of CV complications in post-acute COVID individuals.
To unravel this enigma, we ventured on a mission. We conducted a cross-section study involving 300 individuals affected with COVID infection during the time period of May 1st, 2020 to December 31st, 2021. Aged 21 to 45, all previously healthy individuals. Equipped with a semi-structured open-ended questionnaire where we did face-to-face interviews and asked the participants for common signs and symptoms indicative of cardiovascular pathology.
The results were eye-opening. Among our participants, an astounding 21.6% suffered from palpitation, 13% complained of shortness of breath, 8% showed chest pain, 4.3% palpitations, 2% swelling of feet, and 1.68% drive dog syncope. These symptoms showed a delayed onset in majority of the cases.
Let's probe a bit around the molecular basis of long COVID pathology. When the virus enters the body, it carries a spike protein with two essential components, S1 and S2. S1 binds to angiotensin-converting enzyme, leading to its deregulation, while S2 facilitates the virus fusion with the host cell. Normally, S1 converts angiotensin 2 to angiotensin 1 to 7, triggering protective responses like anti-inflammation, antifibrosis, and vasodilation. However, the virus disturbs this balance by reducing ACE2. As a result, angiotensin 2 binds more strongly to AT1 receptor, causing vasoconstriction, inflammation, and fibrosis. In a sense, the virus disturbs this balance by reducing ACE2 system, affecting cardiovascular and inflammatory processes in the body.
Let's pay our attention to three major theories and the working principle of long COVID. The first theory being the activation of latent viruses. These viruses, they dormant within our body and periodically reactivate, causing recurring symptoms and illnesses. The second being the theory of chronic inflammation. Systemic inflammation can ensue due to persistence of lingering inflammatory cells, which can damage our body's organs and tissue. And the final theory, the autoimmune response. Exaggerated immune response can generate detrimental molecules which destroy our body's organs and tissues.
In our exploration of long COVID's underlying theories, we unveil the striking gender-related and lifestyle patterns of post-COVID serious symptoms with tapestry of knowledge emerging from it. These threads, seemingly distinct, converge to paint a more comprehensive picture of these mysteries and health implications we face.
There was a significant link between females and greater occurrence of post-COVID cardiovascular symptoms, with 45.28% of females examined experiencing at least one symptom. Conversely, males had a lower occurrence, with 27.83% experiencing at least one symptom.
Those reinfected with COVID-19 showed a higher prevalence of post-COVID severe symptoms, with 54.83% reporting at least one. On the other hand, non-reinfected individuals showed a notably lower rate of 31.59%.
The incidence of chest pain and shortness of breath were more prevalent among people with habits than those without. Chest pain affected 15.38% with habits and 5.9% without. Shortness of breath affected 16.9% with habits and 12.34% without. Fatigue affected 15.9% with habits and 12.34% without.
Our study showed that symptoms differ based on the physical activity levels of individuals. Chest pain was reported more among individuals with higher daily physical activity. On the other hand, individuals leading a sedentary lifestyle reported shortness of breath and fatigue more often.
Additionally, we compared post-COVID cardiovascular symptoms in hospitalized and non-hospitalized individuals. Despite finding slight variations, our study did not support our initial hypothesis of having distinct variation between these two groups.
Lastly, we delved into the vaccination status of individuals and its correlation with the cardiovascular symptoms. Those with incomplete or first dose vaccination status showed a higher prevalence of chest pain compared to those with complete or second dose and booster dose vaccination status. These findings shed a glaring light on the chronic nature of COVID-19 and its profound impact on the human heart.
Having uncovered the significant link between gender and lifestyle-related nuances in the post-COVID cardiovascular complications, let's pivot our gaze towards the future direction.
These revelations may guide us towards essential considerations in the realm of post-COVID cardiovascular care and intervention. The key points of them being:
Raise awareness among healthcare providers about the high occurrence of cardiovascular symptoms for early diagnosis and targeted care.
consider gender-specific approach for management of post-COVID symptoms as females show a higher prevalence.
Monitor individuals with SARS-CoV-2 reinfection closely due to the increased risk of post-COVID symptoms.
Promote healthy habits considering the link between cardiovascular symptoms and habits like smoking and its specific symptoms.
Develop tailored physical activity guidelines, especially in those with post-COVID chest pain and shortness of breath.
Emphasize the importance of ongoing monitoring and research for deeper understanding of COVID-19's long-term effects on cardiovascular care and interventions.
In the wake of our journey through the intricate landscapes of COVID-19's enduring impact on the human heart, one truth stands resolute. The curse that scars the heart is a tale that should never vanish into obscurity. As we reflect upon the chronicles of this pandemic, let it be a vivid reminder that its effects are not to be forgotten.
The lessons learned must not wither away. As we march forward, we are called to action to raise awareness and to foster understanding. As we conclude, let us remember that this journey is a saga of hope, a chronicle of discovery, and an epic of healing. We march forward as guardians of not just our own hearts, but the hearts of the world. Battered but resolute. Thank you.
Maybe because of so many other factors. So that's the first question, that all the symptoms may not be directly attributable to the cardiac environment, right? Then other thing is, how many of these people had other confounding illnesses? How many of them were diabetics, hypertensives, how many had dyslipidemia, and how many already had a history of in the family? So that also is important to know. The topic is very relevant, and post-COVID we are seeing a lot of cardiac problems. That's very true. So the topic is that, but I think it's a cross-section study, probably time limitation, but you needed to do more investigations. So justify how can you attribute these symptoms to cardiac problem alone, and whether there were any other confounders.
Thank you for the question, ma'am. Actually, investigations was our limitation, but to eliminate that, our exclusion criteria was individuals without any chronic illnesses. And as we are lacking of time and logistics and investigation, so we did not delve into greater details, but we look forward later on.
So have you maintained a database of all these individuals, and you'll be able to contact them when you wish to later on? Because you said that you have taken a history and ruled out chronic illnesses, but many of the chronic illnesses may be silent or undiagnosed. For example, pre-diabetes, you won't know till you test for it. Chronic kidney disease, it affects around 15% of our population, completely asymptomatic. So I think investigations are a part and parcel of a study, and some basic investigations, even measurement of blood pressure, that would have been valuable. Measurement of pulse rate, at least if not investigation. Anyhow, well presented, and I hope you follow these questions.
Thank you, ma'am. We'll look into it.
Am I audible? Congratulations, well presented. Topic is very relevant. Post-COVID, lot of complications we are seeing, no doubt about it. But I have a few questions to ask. Just to clarify, you told that you ruled out cardiovascular, endocrine problems in these studies. How did you rule out?
Thank you for the question, ma'am. We have asked beforehand for any diagnosed chronic conditions, if any, to the participants we have taken into consideration. If there are any other chronic conditions which are diagnosed before, we have left them out of our study, ma'am.
That means you ruled out these physical problems through history. It may or may not be accurate. Maybe sometimes.
I would like to add a point, ma'am. We also ask these individuals if they are taking any medications. So, like that also we have looked into.
Yeah, that's what I'm telling you. Through history only.
Yeah, yes, ma'am.
You did not do any tests or anything. And one more thing is you have noted symptoms. Okay. But these symptoms, are they causing any disability? Are they causing any limitation? See, the person had COVID, then they developed this cardiovascular symptoms, shortness of breath, chest pain, breathlessness, all these things. Are these symptoms, are they causing any limitation in day-to-day activities of the person?
Thank you for the question, madam. In majority of the cases, the symptoms were milder. However, in few individuals, we have seen that they went to hospital, they were facing dyspnea, they were facing lack of sleep due to the symptoms they are suffering from.
Okay, they went to doctor. Then what did the doctor say? When were they subjected to any investigations? Maybe that question is a repetition. Already madam asked. If you would like to add, you can.
We have asked for the treatment history of the madam. They have said that they were treatment symptomatic. Symptomatic treatment was what they were prescribed.
Means no investigations were done.
We did not take the history for any test, madam.
Then how long these symptoms were there when you required?
Madam, according to the WHO definition, we have ruled out any.
No. These symptoms, chest pain, fatigue, shortness of breath. These symptoms, how long they have been there?
For many of them, they are still facing the symptoms, madam. However, some face the symptoms for duration of months, couple of months, madam. For 3 months, for 4 months, for 6 months. Thank you.
Okay, very well presented. In the second objective, you have mentioned that you want to assess the risk factors. So what, according to you, were the risk factors here? You have stressed more on the symptoms. I did not see any particular risk factor as such. Would you like to comment on that?
Thank you for the question, sir. We have studied symptoms as a risk factors, sir. Like habits.
Symptoms are something different, risk factors are something different. Right?
Any habits
at risk of developing the disease.
In our study, we have seen that individuals with habits had more symptoms. So, habits might be a risk factor for development of post-COVID symptoms. Also, physical activity. Stressing my point on physical activity, chest pain was reported more among individuals with higher physical activity.
And one more thing, did you see any correlation with the duration?
Pardon, sir?
Duration of COVID. All were not having the same duration of post-COVID period, right? Some may be 3 months, some may be 1 year. So what was any correlation with the system at the time?
Thank you, sir. We have taken the hospitalization history, sir. However, the participants seem to exaggerate the symptoms they had, so we cannot. Thank you.
I would like to add a point, sir. Gender is a risk factor. Like as females are showing higher prevalence, so gender is a risk factor. Thank you.
Very well presented and very interesting study because you went out to the community to find out what's happening with those people who have gone through COVID infection. So my one question, what is that one recommendation you give, even though it is a small sample size, that you will recommend to health workers and to the community people who are COVID infection? One recommendation.
Thank you for the question, madam. Actually, our target population are the health workers at the road level, madam. To prevent this, any further complications of post-COVID symptoms like heart attacks, we have to educate health workers of post-COVID symptoms and the risk factors more frequently.
I need to say like, okay, what is the recommendation based on your study? That is, what is that we should be doing now about this?
Ma'am, we can raise awareness among healthcare professionals, we can raise awareness among ASHA workers and PHC centers so that it would lead to early diagnosis which can prevent further complications of those symptoms.
Adding to my friend, madam, due to the symptoms being milder in many cases, people tend to overlook these symptoms very easily, madam. And because of the chronic nature of the condition, many are not consulting a physician about this, so that might be a problem.
I just want to add to some points. Like there are some rehabilitation program. Respiratory rehabilitation is there where we can do a chest expansion and we can make the airway clearance and we can ask them to have changes in physical activities. There are exercise training also like resistance training and intensive care training. So we can ask them to have rehabilitation programs and when they start in tele-rehabilitation training we can follow later on if they have severe problems with serious. Thank you.
Thank you, ma'am. Thank you.